Hello everyone, how are you all? How are you doing? How's my recall batch is going on and the other batch as well, the regular one? I saw so many students, even from the one as well, that is who just passed the exam as well. So first of all, I congratulate to the November one. Lots of students cleared the exam. I'm very happy for them. And I saw a few students from my regular course as well. So how's your preparation going? Let me tell you that it's in a very interactive session. You can even type, you can even voice a mail or something. So I get to know what queries do you have.
Yes, the overall result of November batch was extremely amazing, and a lot of students have shared their emotions and expressed their like how they have found the course very very helpful, and about the mentors as well. So I would like to congratulate all the students who have cleared the exams. All the best wishes to them. So and all the students who haven't cleared, like we truly understand those people who haven't joined the courses and they have studied by themselves and they have failed the exam, but don't worry, we are always there for all of you. So Dr. Nabira is going to let you know how you are going to ace the exam. So we are going to talk about all these things in further slides. I guess, Dr. Nabira, we can start now.
Yes, sure. So first of all, to those students who didn't even clear up the exam, they just even about to clear, they are like on the 249, 248. So you guys don't even need to worry. It's like about your guys just get a one BCQ, that will be the wrong one. So you don't need to worry about it. Just share your results, that where you lacking it, in which subject you are lacking it. Either it is gynae, either it is medicine, or any other subjects. So you guys are well prepared. You just have to take the recall sessions and just you have to make up through your exam. 249, even the 240s are even very very safe. You just take the course. You just need the guidance and nothing else. You just know everything. Just need a proper guidance regarding the course, regarding how to approach the BCQs, regarding how to solve it, how the time calculation, whatever the query you have, you can even personally message me. I will be available for you guys. Okay, yes, we have new students as well with us. So first we need to tell them that we have the how the exam will come in and how they will proceed with it, what time they will give you, and how many questions they give in the exam. So these are the details. Like you have 3.5 hours for your exam, right? You have 150 questions. So you have maximum time if you have done with the recalls, if you have done the practice questions, if you have done the flashcards. So 150 questions in this time period, I guess it's very enough for you. Among the regarding the we talk about the distribution, that is very important. Like we have major portion of medicine, we have my major portion from surgery, and then we can say that ob-gynae and pediatrics have a similar ratio, and then mental health, that is very important. Like mental health, gynae and surgery, these three subjects I get the query a lot, that people will fail difficulty in solving these questions, and when you didn't even get the right question, they get you the same question again and again. So when this happens with you in the exam, your distribution of questions will be different. Like, for example, if someone is incorrecting the question regarding the psychiatry, he or she will get the say 7 or 8 question from similar of the psychiatry. But if the same person can correct the psychiatric question, he or she will get the 3 or 4. So your distribution will be changed according to your answer. That's why we say that it's an adaptive system, because I heard the complaint after the November result that doctor, I get the 20 question from psychiatry, and it was just I was very much happy with that I just clear in the first time and I get very low marks in gynae, just because he did get the 20 questions because it was the tough questions, so he cleared the exam. And the gynae portion, he get the very few question, but it was when the result came, it was showing a less bar for the gynae. So he was very happy because mental health have a very strong component on AMC. So he just cleared that 20 questions, and that 4 question didn't even meant for the passing marks. So he just passed it. Similarly, the guy came and complained that I didn't even get the 2013 question from the surgery, and it was very difficult, and all the question from the debridement and vascular surgery, that how you will approach for the heparin and thrombocytopenia and this and that. And I just get very confused just because he was doing that question wrong again and again. So they will giving you the surgery questions. That's why we say that they have an adaptive system. That's an AI system. Whatever you answer it, you will get this next question according to it. So this is the standard distribution, but make in your mind that whatever the question you are doing it wrong, your distribution of question will be changed according to your answer. This is what we call that computer adaptive exam. And the third thing, what I prefer and what I realize from everyone's result is that it does not depend on that you are wrong the answer. It is depend on how much you wrong the answer. For example, if someone say that a investigation of choice for the breast lump is ultrasound, that will be the right one. But if someone mark it X-ray, that will be the wrong as well. But if someone mark it that you will go for the CBC, that will be very wrong for it. So it depends that how much wrong you are doing for it. Because it's an AMC is the only system that is a scaling system, not a passing or scoring system. Like they will give you a score from 500 till you have to pass from 250, right? So they will scale you according to it. And they have to maintain a standard as well that how much people answer the CBC, because it's very wrong. So if 50% population mark the CBC, that will be the very wrong answer, and that will they consider it that it is a kind of difficult question. But if you are the only one who marked the CBC and everyone marked the ultrasound, so that will be means that you are lacking the knowledge. So your mark will be more reducted. This is how the AMC system works. That it is not about the wrong, it is about the more wrong and how much wrong you are doing and what you are getting, because it's an AI system. So they can check your capability by every aspect, each subject, each answer you give right, each answer you give wrong. Similarly, if you give the answer for any type of for example, they give you a case of borderline personality and everyone mark this bipolar disorder, and you mark the borderline personality, you get the highest marks. And your questions will be, you can pass even on 90 questions and other person will pass on 120 questions just because you even mark the right one. That will be a difficult task, but your knowledge is very good, so you will pass on very less questions. So just don't worry about it. Just make your knowledge strong about it. And from the question that how you can approach it, how you can solve it, this is what AMC is. Time is so much enough when you have a good practice. 150 question, like in how in even a person who is having a good practice in 45 minutes can even go from the 100 question in a one go without even thinking that I am tired or something. And our rest the 50 question will be nothing. All the techniques can be even applied when you have a strong practice on BCQs. That's why my basic even I'm always emphasize that please solve the questions. These are for those people who even just fail on the 240 till 249, because you have already a strong knowledge. You have to just get the tips that how to crack the questions. You don't have to need to go for the whole theory, just you need to go for the practice sessions. You need to just get the approach that how you can approach the questions. Another thing that I am very concerned about it, that because was my first time I take the November recall session, and I never know that I will get the this much overwhelming, this much very happiest response from the everyone, that everyone was expecting that I will tell you the answer of the recall. So this approach is very wrong, because I just mentioned in the every exam that recall is a human error. Human just remember what he or she cannot even solve. Only it's your being a resident of psychiatrist, I need to tell you that you only remember what you cannot even solve and what you cannot even try to get the real answer or right answer. You cannot even remember the question which you even solve in a one go. Your brain, whenever your brain will stuck on something, that thing you will always remember it. Either you can remember in a good perception or in a bad perception, or you make a distorted image of that question. So this thing I just tell my November people who have recall session with me, that don't go on the question. Just remember that this topic came in the exam. So just what you need to do is just go through the whole topic, because if someone they ask from the investigation of choice, so they will probably ask you the treatment of the choice. So if you are going to to this thing, doctor, tell me the answer of this question, that never gonna work. And what I guess, I just saw the chat. My few students who just fail on 249 and 248, those are the one even who just begging me for the answers and not even going for the whole topic. Despite of I just said lots of the time that just go through the topic, because human error can be even possible. And those students who just happy with this thing, that just go through the topic, we cleared the score with 289 to 73. That's very amazing score I just saw in the November exam. So make your approach that in from the fab recall, you will have to go through the topic. And 249, 248 is just only a one BCQ you just left the incorrect. You will be passed in a one go, trust me. And it's not the end of the world. It's just a, we can say it's a misfortunate, or it's just a very kind of little bad luck. You will even get it. Okay, topic from where and source. Whenever the someone come from the exam, they will let you know that doctor, it's come from a cat scratch disease, and there was a scenario, and I just take about the lymph node and something. So you need they tell you that the topic was cat scratch disease. So what you need to do is you need to do the whole topic. It's available in the John Murtagh. It's available in the course. Even med expert are giving the amazing thing that they are even particularly give you each topic's flashcard, individual topics, BCQs, and individual topic alone. This is the amazing thing. If you go in their website, that you don't need to even rush in the last minute for the book. Just go for the whole book and go through in this thing. Med expert even give you the important topic list, as these are important, and they will give you in a very perfect example with upgraded RSCGP guidelines. So at the end, not go through the just recall answer that I want the answer, what will be the answer. Just go for the whole topic. This is what I did with my November session. Okay, doctor, the question you have asked is regarding that Australia did not even give you for any particular regarding exam visa. You have to apply for the visit visa. So now we come to the main thing. Those who are new, those who have started preparation, and those who are about to start the preparation. Yes, this session is for the multi-purpose thing. Those who just pass the exam will ask their own question. Those who fail the exam will ask their own questions, and some recall questions, and other people who have some practice question as well. So it's a topic for multiple purposes, and we have a practice question as well. I took the main practice questions that will be the difficulty in exam, and have more pronounced like they are major difficult, or they cannot even solve in the exam, and people find it very difficult. So I put that 40 practice question as well. That will be discussed after discussing the main queries of that people. Okay, for the preparation time, 3 months for the those people who we can say that you have just failed, or you don't even get the time to just you have did book your exam and don't have time to just recall whole course. So you can get even 3 months of preparation. Those who have a time and didn't even get the full preparation and don't have time having doing jobs or something, you can
Dr.
I
Nabira,
might.
yeah,
Okay, sorry for the interruption. Am I audible to everyone?
yes, Dr. Nabira, you are audible.
Okay. So those who have already booked their exam and have only just 2 months for preparation, better to go for the recall sessions. Because if someone is having a lot of time, you can have and go for the proper course for the regular course. And if someone is having a very lack of time, then you have to go for the recall course as well. Okay, so these are the things that is very important for cracking the AMC. That first you have to find the study partner. This is the foremost goal. That when you join the course, there will be lots of people who have you matches your energy, your time, and everything. You have to just find the one partner according to your time zone and everything, right? That will be more important when you precisely solving the recalls. So that will be help you because you one have a good knowledge for example, surgery one have a good knowledge for gynae, so you both having can solve the recall easily. Another thing is guidelines are the key. Mock exam, solving practice, a med expert will provide you everything for that. So don't need to worry about it, that how you can get the questions, how you will get the BCQs practice. They are providing everything. Regarding the guidelines, we all mentors are very much updated with the recent guidelines. Either it's about the gynae, psychiatry, or any subject. So what you need to do is just you need to read it. You don't need to find it about it. Anything you don't find the guideline, just I am one text away. Similar goes for the other mentors as well. If you find any difficulty, you just text us and we will properly give you the guideline. Next thing will be the consistency. Consistency is for everything. Yes, doctor, you can definitely get a job after AMC1. That's why we are more emphasizing you just take the course and just go through the exams. Anything regarding the PDF of John Murtagh handbook, practice questions regarding PDF, Med Expert will provide you everything, right? Just you need the consistency of regarding course. Every mentor will give you the course, even will ask you about your preparation and everything, like a spoon feeding thing. So what you need to do is just consistent with your exam and with the course and with the guidelines and with the slides we are providing. Okay, so we were starting the few practice questions. I just bring those questions. Okay, these courses details. I would like to Asma to just give some courses and details about the AMC and everything. Asma, can you please elaborate it?
Yes, surely. Let me just quickly share my screen so that I can share the features of our Recall Crash course and all the students who haven't joined us yet and they are deciding of starting their preparation so they can use this course to start their preparation for the AMC preparation. So, in the Recall Crash course, what we are doing is we are providing 15 interactive live sessions with the most experienced mentors, Dr. Sumaya, Dr. Chinmay, Dr. Nabira, Dr. Fahad. These all four mentors will be there for your guidance for each and every live session. So we also provide the recording of every live session. So in case you'll miss any live session on the very next day, we provide the recording and the PDF as well so that you can quickly revise all the notes that you have covered in the live session. Then we're going to provide you the mini mocks, the quizzes, and the topic test that you can use to practice as much as questions as you can. So total, we are going to provide you 5,000 questions with correct answers and explanations so that you can practice as much as questions as you can. And apart from all these things, we are going to provide you the notes and flashcards. So in case you face any difficulty in the theory part, what you can do is you can go through the notes and the flashcards and your theory will be well prepared. And also, if you need any book or important files like guidelines, so we are going to provide you everything in the course. And apart from all these things, we are going to provide you the recalls of 2024 whole year that will be month wise, day wise, so that you know how AMC gives the questions and you can understand how the question structures are basically so that you can understand those questions in your real exam day. So now let's see at the schedule that we are providing. So in the Recall Crash course, how we do the course is that we have divided the course in topic wise and system wise modules. So first we're going to start with the medicine module. So in the medicine modules, we will be having 4 live sessions with Dr. Chinmay. And on the days when there is no live session, we are going to provide you the topic test that will be relevant for the medicine module, like respiratory, like renal, like urology, like all the topics that are related to medicine system. They will be provided in this week particular week so that you can practice as much as topic test. And then by the end of the module, we're going to have a recall discussion in the study group. And or a moderator, Dr. Aisha Iftikhar, is going to conduct the activity in the study group so that it will motivate you to solve as much as questions as you can. And then we are going to move to the next module, that will be surgery. So similarly, we are going to cover system-wise all the questions. And we have added one special feature in the Recall Crash course, that is the paper discussion. We have kept this module for all the students who want to practice 2024 recalls as well. So for paper discussion, we will be having 3 separate sessions with Dr. Nilufar Abru so that you can discuss questions with her. So now let's quickly, let me share you the website view of how the website will be when you join the course. So we have our separate website on which we are going to provide you all the access of the crash course. So once you enroll in the course, you will see this dashboard on your profiles. And in the course dashboard, you will see recalls, you will see notes and flashcards, you will see topic tests, you will see the recordings of the sessions, you will see books and guidelines, like all the material that you need for your best preparation. Then in the supporting content, we are providing you all the recalls. Like I told you that we are going to provide you 2024, February till November, all the recalls that will be month-wise and day-wise. And then we're going to provide you the question bank that we have divided in 5 chunks. So in first, you will get topic-wise test, you will get quizzes. In the second, you will get important quizzes so that you can attempt and assess your preparation. Then we're going to provide you separate recall quizzes in which you will get all the recall questions with correct answers and explanation. And then once you're done with your preparation, just before your exam, we are going to provide you the important high yield quizzes and the mock exams that will be just like the real exam so that you can practice those questions before your actual exam day. So this is the whole material that we are providing for your best preparation. Just let me quickly give you an overview what is in each module. So in the recalls, you will get orientation session, you will get recall recorded sessions that you can use for your self-study as well. And then we have provided the solved recall file PDFs in which you will get 2023 till 2024, all the recall files with all the important scenarios, all the questions. Then we are providing important recalls that are topic wise. So this all you will get in the recall section. Then in notes and flashcards, you will get notes for each and every topic. And then in the flashcards, you will see all the flashcards that you can use for your last minute revision. And then in the topic test, you will get topic test for each and every topic that you want to practice. So let's suppose if we are starting with the medicine module. So once you have you are done with the live session, then on the very next day, you can attempt the topic test for the medicine like dermatology, like respiratory system. You can just practice those questions. It is with proper timing and with the number of questions also mentioned. And then we have topic wise quizzes. So once you're done with each module like medicine, you can just practice those quizzes for assessing your preparation. Then in the recordings, you will see all the session recordings of the sessions that we are conducting. So once there is a live session, on the very next day, you will get the recording over here. And if you need any book, then all the books are here. Like you can name the book and you will find the book over here. Like we have Kaplan series, we have John Murtagh, we have notes, we have RCGP guidelines, like all the books that you need for your preparation, you will find every book over here and with guidelines as well. And you can also download this book for your self-study preparation. So this was all about the course. So now we're going to continue with the MCQs. Dr. Nabira, over to you.
Yes, sure. So you'll practice some questions. That will be the most high yield questions, and most people have the problem in that. So we're starting with these questions.
So, Dr. Nabira, we have Dr. Muhammad Fateh who have cleared his exam in November batch. So he has shared his good wishes to you. He was driving. He wanted to talk to all the people out there and share his advices. So he has written a note for you.
Yes, Dr. Fateh, thank you so much. The video you have sent is very amazing, and I'm very much grateful to you. So we will starting with the question today. We will start with the obs gynae, right? So, it's a very interactive session, so you will just mark your answer, and then I will reveal the answer. So, Dr. Fateh, are you ready for the recalls again, or it feel like a nightmare right now? First, I give you a warm welcome to the recall students, and that will be the very. I will have a very good sessions with you. Don't worry about it. Don't hesitate to ask any questions. This is an interactive session, and next questions will be the interactive as well. Whenever you find any difficulty in this session, even the session after, you can even message me regarding your query, and I'll probably try to query it away, right? So we'll start with gynae. A patient come to your office with her last menstrual period 4 weeks ago. She denies any symptoms such as nausea, fatigue, urinary frequency, or breast tenderness. She thinks that she may be pregnant because she has not had her period yet. She is very anxious to find out because she has a history of a previous ectopic pregnancy and wants to be sure to get early prenatal care. Which of the following actions is most appropriate at this time? Anyone? I want everybody to answer. There are like 45 plus students in the class, so everybody please answer. I guess most of you answer the question. Let's see the right answer. So the answer is B, but half of the people answer the A. So the nausea, fatigue, breast tenderness, and urinary frequency all are common symptoms of pregnancy. However, they are not specific symptoms and are not consistently found in early pregnancy. So on PE, the pregnant uterus enlarge and become more bulky and soft, but these changes are not usually apparent until 6 weeks. But in that question, they mentioned that she's on the 4th week of gestation. In addition, other conditions such as adenomyosis and fibroid may result in an enlarged uterus. Ultrasound will not demonstrate a gestational sac until a gestational age of 5 to 6 weeks is reached, nor will it detect an ectopic pregnancy at the time of the missed menstrual period. So it is therefore indicated in this patient to go for the option B. A Doppler will detect fetal heart rate tones usually no sooner than 10 to 12 weeks. A serum quantitative pregnancy test can detect HCG level by 8 to 9 days post ovulation, and it is therefore the most appropriate next step in this patient. But why I'm just giving this big explanation, just remember that the weeks I mentioned, because this will help you to solve the question. That 8 and 9 days will be detectable for the HCG, for if you want the ultrasound, Doppler for fetal heart rate, for that will be the 10 to 12 weeks, and for pregnancy to be demonstrated on the physical examination, that will be for the 6 week of gestation. So remember these week, so that will be more helpful for you when you're solving the questions. Next question will be 28-year-old G1P0 present to your office at 24 weeks of gestation for an unscheduled visit secondary to right side groin pain. She described the pain as sharp and occurring with movement. and exercise. She reports no change in urinary or bowel habit and no fever or chills. Sitting down and putting her feet up helps elevate the discomfort. As her obstetrician, what would you tell her that most likely etiology is? Okay, my question is why you guys are not thinking about appendicitis in this patient?
So sitting down and putting her feet helps to alleviate the discomfort. This goes in favor of round ligament.
Okay, very good, doctor. What's your name?
My name is Dr. Siraja Munira from Bangladesh.
Okay, very nice, doctor. You give a very good explanation. So the answer is round ligament pain. Each round ligament extend from the lateral portion of the uterus below the oviduct, travel in a fold of peritoneum downward in the inguinal canal and insert in the upper portion of the labia majus. During pregnancy, these ligaments stretch as the gravid uterus grow further out of the pelvis and can therefore causes the sharp pain, particularly with sudden movements. So round ligament pain is more frequently experienced on right side due to dextrorotation of the uterus that commonly occur in pregnancy. So usually this pain is greater, improved by avoiding, yes, doctor, sudden movements, changing position slowly, and by sitting and elevating the feet. Local heat and analgesia may help with control the pain. Another thing is that whenever there will be urinary symptoms and fecal incontinence symptom, that can be we say that when the appendix is more likely for the pelvic region. So these symptoms will be come over there. If the symptoms come like more frequently urination, pain while urinating, then we will think about UTI and we can think about the urinal stone as well. So these symptoms are not there. Also in appendicitis, the first thing that will become is mildly feverish feel and the vomiting. Vomiting will be pronounced in appendicitis. So these are the symptoms regarding appendicitis and sometime AMC ask about the round ligament question and sometime ask about the appendicitis in pregnancy. Okay, a pregnant woman who is 7 weeks from her LMP comes into the office for her first prenatal visit. Her previous pregnancy ended in a misabortion in the first trimester. The patient, therefore, is very much anxious about the well being of this pregnancy. Which of the following modality will allow you to best document fetal cardiac activity? Yes, doctor, you give a right answer about it. Okay, this question came in last November recall exam, and most of the people, I don't know why they give the answer or the similar mistake, the human error that people say that it come is a in the form of a fetal Doppler stethoscope. So the answer was transvaginal ultrasound. I don't know what they ask in the exam, but most of the people did this question wrong because vaginal ultrasound can detect fetal cardiac activity as early as 5 weeks after a missed period with a traditional stethoscope. Fetal heart tones can be heard starting between 17 and 19 weeks of gestation. Doppler stethoscope can detect fetal heart tone by 10th week of gestation age in non-obese women. Okay, move to the another question. What would the next best step in the management of if the patient were 41 weeks with an unfavorable cervix and oligohydramnios found on ultrasound? Doctor, do you think that in Australia you will go for the C-section directly?
No, there is no absolute indication for cesarean section here.
Yes. So you cannot go for the A now. So I guess most of you give the right answer regarding this question. The answer is B. Patient with oligohydramnios at term should be delivered. If there is no contraindication to vaginal delivery, the patient should be induced, right? The patient with an unfavorable cervix may undergo cervical ripening after assessment of fetal well-being. If the fetal testing is reassuring, the unfavorable cervix can be ripened with a variety of mechanical and pharmacological agent prior to initiating pitocin, right? Pharmacological agents include PGE2 preparations available as vaginal cervical gel or vaginal insert. Misoprostol synthetic analogs has been used off-label for pre-induction cervical ripening and labor induction. Even it can be administered via oral and vaginal route as well. So for the mechanical ripening of the cervix can be achieved with laminaria, which is a hygroscopic dilator that is placed in the cervical canal and absorb water from the surrounding cervical tissue. The cervix can be mechanically dilated with a balloon catheter. Pitocin is not considered a cervical ripening agent but a labor-inducing agent. So in patient with oligohydramnios, cervical ripening should be performed in the hospital under continuous fetal monitoring and therefore is not appropriate to provide a ripening agent and send her home. And even we can say, if we can say that if the patient is no, these all are the condition we are doing when there is no contraindication. But if there is certain contraindication like fetal heart rate is dropping, or there will be some damage to the fetal, then we will go for the another option as well, and we will think for the C-section. Okay, move to the next question. A 16-year-old primary gravida present to your office at 38 week of gestation. Her first trimester blood pressure was 100 by 72. On the day of presentation, it was 170 by 110. And she has 4 plus proteinuria on a clear cat specimen of urine. She has significant swelling on her face and extremities. She reports no contractions. Her cervix is closed and thick. The baby is breached by bedside ultrasound. She reports the baby's movement have decreased in the past 24 hours. So, which is the next step in this patient? Doctor, why you are inducing labor over here? Despite of knowing that in past 24 hours there is no, we can say that movement of the baby. So why you are inducing labor over here? Also, there are 4 plus proteinuria. If you induce the labor over here, the patient is directly going for the epilepsy as well. There are lots of conditions that you cannot even go for that. So, preeclampsia is diagnosed by noting new onset of hypertension and either proteinuria or end organ dysfunction after 20 weeks. In round 13, ACOG eliminated dependence on the diagnosis of proteinuria. In the absence of proteinuria, preeclampsia is diagnosed as hypertension in association with thrombocytopenia, impaired liver function, new onset of impaired renal function, pulmonary edema, or new onset of cerebral or visual disturbance. Gestational hypertension is diagnosed if the patient develops hypertension without proteinuria or the aforementioned systemic findings after the 20 weeks of gestation. So chronic hypertension is hypertension that predicts pregnancy, and superimposed preeclampsia is chronic hypertension and associated with preeclampsia. The treatment for gestational hypertension and preeclampsia term is delivery, right? But our case is complicated.
Yes,
So
there is
selective.
two point for cesarean section. One is primary with breast. Breast is also indication for cesarean section, and patient is severe preeclampsia. So, severe preeclampsia means that the indication for termination of pregnancy and the mode of delivery must be cesarean section.
Very good. That's why we say that selective preterm patients may be managed conservatively at home or in the hospital depending on the severity of the hypertension. BBP testing is useful when following the patient conservatively. Although the bed rest may transiently improve elevated blood pressure, a full term should be delivered based on the severity of this patient's blood pressure. She has preeclampsia with severe features and she should be delivered by C-section, right? Since this patient's fetus is breached, cesarean section rather than induction of labor is the next best option in the management. Diuretics should not be used in the Management of preeclampsia as they deplete the maternal intravascular volume and may compromise the placental perfusion. Okay, a 32-year-old woman present to the emergency department with abdominal pain and vaginal delivery with abdominal pain and vaginal bleeding. Her last LMP was 8 weeks ago and her pregnancy test is positive. Her blood pressure is 85/65 and her pulse is 1110 beats per minute. On examination, her abdomen is distended and tender. A bedside ultrasound shows free fluid within the abdominal cavity. The decision is made to take the patient to the operating room for emergency exploratory laparotomy. So, which of the following is most likely diagnosis? Okay, doctor, why you guys are now not going for a hydrated mole or a torched ovarian corpuscle luteal cyst?
Here there are some of the clues for ruptured ectopic pregnancy. First of all, short period of amenorrhea, 8 weeks, followed by paroxysmal bleeding. Patient going to shock, that is BP is lowering with a rising of pulse rate, and the most importantly, abdominal ultrasound shows free fluid. That goes in favor of the ectopic pregnancy, not hydrated for more.
Okay, let's see what everybody will answer. I guess everybody give the right answer, but if I change the situation, that if I say that a patient is vitally stable, so what you will go for then? Anyone?
Ultrasound peritoneal fluid collection. The patient is
Let's
stable,
suppose,
but is there any peritoneal collection on ultrasound?
let's see, I say that a patient is vitally stable and there is no fluid on the ultrasound, then what you will make the diagnosis over here? Very good.
Yes,
Then
hydrated
we
from
will
one
go
is over.
then we will go for the cyst, then we will go for the rupture cyst, or there will be a stretch over the cyst, or we will say that there will be a torsion like symptoms, right? Because that type of severe pain with some time normal BP, normal vitals, no bleeding, we will go for the rupturing of the cyst. But if I mention about the some weak or something, and when say that a patient is bleeding and there will be already rule out there will be no ectopic pregnancy, then how you will proceed this case? Very good. Then we will think about the abortion. So this is the way. That's why I'm emphasizing and changing the scenario, that if one scenario came in this way, then this slightly change the question for the even next group of the exam. Like for example, Monday people will get the rupture ectopic pregnancy. Tuesday people will get the even misabortion or something. They just slightly change the scenario. This is how the AMC will trick you, and the whole question will be wrong if you don't go through the topic. This is the only slightly things you have to go through, right? The most likely diagnosis in this case is rupture ectopic pregnancy, molar pregnancy, incomplete abortion, and misabortion can also be associated with abdominal pain and vaginal bleeding, but would not be associated with free fluid within the abdominal cavity, hypotension, and tachycardia. A torus ovarian cyst would present with intermittent abdominal pain. The ultrasound would show a pelvic mass with no Doppler flow to the ovary, not free fluid. See, this is the only one thing they will exclude in the scenario and they will give you. So the whole scenario will be changed. Okay. 18-year-old G1P0 at 8 weeks of gestation presented to your office for her first prenatal visit. She reported daily nausea and vomiting over the past week. Which of the following sign or symptoms would indicate a more serious diagnosis of hyperemesis gravidum? I guess most of you give the right answer regarding the hypokalemia. So this will be the right answer over here. But the thing is that in the first of exam in October and September, recall they give the sign and symptom, and for the another day of exam, they will ask you regarding the treatment. So if the same scenario is given, so what will be the treatment of hyperemesis gravidum? Anyone? Your first question would be here is that, doctor, this patient came to the GP setting or either this patient came with the setting of ED, because both of the patient setting is changed. Because if the patient came to the GP and she is vitally stable, so the treatment will be different. But if the patient came to the ED, your first goal would be vitally stabilize the patient. This is how you will approach the patient, right? Another thing is that if we need to see that we need to see that it either it is mild, moderate, or mild to moderate, or it is severe. We need to see that as well. Because vitamin B6 that we will say that will be the paradox, then will be first line therapy, right? But if the vomiting is mild to moderate, you will go for the vitamin B6 plus doxylamine as the first line therapy as well. But when we say that the patient is having a, we will give a scale to the patient, and in the question they will mention that it is moderate to severe, then we will go for the metoclopramide. That will be the second line treatment. And if we say that the patient came to you and say that doctor, it is refractory, like it is not even stopping, not even patient is very fainting, not even in a senses very hypotensive, then we will add the corticosteroid along with the anti-emetics. You need to make your approach like this, that what will be the first line, how severe it is, and which setting the patient is coming to you. Another supplement like ginger, acupressure, hypnotics, these will be the complementary therapies we need to tell the patient if it is an option, right?
But
So
here
this
the
is
patient
how.
has already developed electrolyte imbalance. So in addition to stopping vomiting and nausea, we have to count the electrolyte, right?
I just give you a question regarding the scenario. In this question, you are very right, but I changed the scenario that I asked the treatment. So I'm talking about the treatment. The patient came to you with a severe. What will be the first line choice? And if it is mild, that you will add the vitamin B6. If it is mild, along with bit of the vomiting, that you will add the doxylamine as well. But if it is moderate, so you need to add the metoclopramide. Regarding the severity, regarding the setting which is patient is coming, you need to answer the question. I will share a guideline regarding a separate chart in the group regarding this as well. So you need to know that which setting patient coming and which type of severity is patient coming, right? Okay, 25-year-old P0 at 25th weeks gestation present to the ED where she has restrained passenger in a motor vehicle accident. She reports she was rear end while yielding at a stoplight. She was wearing her seat belt and the impact was significant enough that her airbags were developed. On examination, her vitals are normal, her fundus is non-tender, but she has bruising on the abdomen from the seat belt. The fetal heart racing is reactive and she has no contractions on the tachometer. She reports light vaginal bleeding, which is confirmed on sterile speculum examination. Her blood group is type A negative. What is the best to determine whether these has been fetal-maternal hemorrhage? Okay, so I guess most of you give the right answer. This is the option C. The KB test is based on the fact that fetal erythrocytes contain hemoglobin F, which is more resistant to acid elution than hemoglobin A. After exposure to acid, only fetal hemoglobin remains. Fetal red cells can be identified by uptake as special stain and quantified on a peripheral smear. An APT test is usually used to detect the presence or absence of fetal blood in a vaginal discharge, often to rule out vasa previa and later pregnancy. A type screen and hemoglobin electrophoresis or CBC will not provide information about fetal-maternal hemorrhages. Next question, 33-year-old G3P2 at 32 weeks gestation developed flu-like illness and breakout with a pruritic vascular lesion all over the body. 3 days later, she goes into spontaneous labor and deliver a healthy baby, appearing male and faint via vaginal delivery. Her lesions are beginning to heal and she feels well. What is the most appropriate next step in the management for this patient for her baby? This is AMC's favorite question they must give in the exam. Either in the November month, October month, this is AMC's favorite topic. Doctor, why you are going to give the acyclovir to the baby?
No, that's a typing mistake. It's not the acyclovir to the baby, it's the
Okay,
bacillus
okay, no
immunoglobulin to the
worries.
baby.
That's so fine. Okay, my question is that if I add another answer along that, you will give acyclovir along with immunoglobulin to the baby. So, do you choose that answer? Okay, so I guess most of you give the right answer, and yes, we don't give this to the baby. That's why I said this option, because in the question, sometime AMC give you this answer as well, and people find it that's a very perfect answer. Give acyclovir and the vaccine as well. So it's not a prepared answer. Varicella or chickenpox is usually diagnosed based on the clinical finding of classic pruritus and vesicular rash. Pregnant women should have varicella immunity documented in early pregnancy by a history of previous infection or varicella vaccine. Pregnant women who have no history of chickenpox or have serology demonstrating lack of immunity should avoid varicella infected individual until their lesion have clustered over and they are no longer infectious. Neonatal mortality rate are close to 25% when maternal varicella develop around the time of delivery due to the lack of protective maternal antibodies and relative immaturity of the fetal immune system. Therefore, if a mother has clinical evidence of a varicella infection 5 days prior to or up to 48 hours after delivery, the newborn should receive vaccination. Typically, varicella infection in the mother only requires supportive therapy, but pregnant women have a higher mortality related to the development of pneumonia. If pneumonia is diagnosed, IV acyclovir should be given. So this is the scenario. That's why I asked that if you give the acyclovir or not. If the patient came, like a baby came with the symptoms like pneumonia or recession of the chest, tachycardia, tachypnea, then you need to even give the both. The newborn should be isolated from the mother if she is infected and the neonate develops signs or symptoms of varicella infection. Then IV acyclovir would be administered. Pregnant women should not receive the live attenuated varicella vaccine. So you need to see in the question that either the baby developed the symptoms or not. In the question, the baby didn't even develop the symptoms. That's why we are not even giving the acyclovir. We will give the acyclovir if the patient is developing a symptom. Remember this thing. So in that case, what I ask you that vaccine plus acyclovir, we give the both. Another question, 29-year-old G1 at 9 weeks gestation present to your office for a new ob-gynae visit. She reports a history of well-controlled hyperthyroidism. She takes 88 mcg of levothyroxine daily. How do you expect her thyroid laboratory values to change during pregnancy? Anyone? I guess everybody get puzzled in this question because this is a very tricky question. And also everyone gave the wrong answer as well. So the answer is E. There are considerable changes in maternal thyroid functional during pregnancy. Maternal total or bound thyroid hormone levels increase with serum concentration of thyroid binding globule, right? TSH decrease in early pregnancy because of weak stimulation of its receptor by HCG during the first trimester. After the first trimester, TSH level return to baseline values and progressively increase in the third trimester, related to placental growth and production of placental deiodinase. Free T4 remains stable during pregnancy. A high TSH and low T4 are characteristics of overt hypothyroidism. These physiological changes should be considered when interrupting thyroid function tests resulting during pregnancy. This is a difficult question regarding thyroid, and they will give such question regarding thyroid. Okay, a 20-year-old G1 at the 18 weeks of gestation is hospitalized for IV antibiotics for the treatment of acute pyelonephritis. She developed shortness of breath and is found to have tachypnea and decreased oxygen saturation. Chest X-ray revealed pulmonary infiltrate consistent with pulmonary edema. What is the most likely cause of this complication? Anyone?
Acute renal failure.
Let's everybody answer it.
Is this intravenous hydration?
Let's everybody answer it. Then I will tell you again. I guess most of the people giving the wrong answer. Only one doctor give the right answer. So the answer is D. Endotoxin release can cause alveolar injury and lead to pulmonary edema and acute respiratory distress syndrome. Endotoxin release can also cause renal dysfunction manifested as increased serum creat, but this effect is usually reversible with fluid resuscitation. The uterine contraction and hemolytic anemia are also effects of endotoxin release. Bacteremia can be found in 20% of women with pyelonephritis, but it is the endotoxin release that leads to alveolar damage. Because that woman, it is mentioned that develop the pulmonary edema, right? While allergic reaction to the antibiotic can cause severe respiratory symptoms, usually they do so by causing bronchoconstriction. IV hydration to ensure adequate urinary output greater than 50 ml per hour is the mainstay of therapy. Careful monitoring of the input and output of the patient is necessary so the fluid overload will not compound the pulmonary effect to the endotoxin. Okay, a 33-year-old woman at 10 weeks of gestation present for her first prenatal visit. Routine laboratory findings are drawn and her hepatitis B surface antigen is positive. Liver function tests are normal and her hepatitis B core and surface antibody tests are negative. So which of the following is best way to prevent neonatal infection? Anyone? Okay, if I change the question that what is the best way to prevent mother, how, yeah, how you will prevent mother from this thing? Okay, I guess everybody give the right answer. Hepatitis B is transmitted by parental and sexual contact, women with multiple sex partner, those who engage in IV drug uses, and those who have sexual partners who engage in these risky behavior are at highest risk to acquire this infection. Infection of the newborn whose mother chronically carries the hepatitis B virus can usually be prevented by administration of hepatitis B immunoglobulin very soon after birth, followed promptly by the hepatitis B vaccine. Now come to the question. The patient returned to see you in 6 weeks for a routine postpartum visit. She has been nursing her baby without any major problem. And you want to continue to do so far for at least 9 months. She is ready to resume sexual activity and wants to know what her options for contraception. She is non-smoker and her only other medication is a prenatal vitamin. Which of the following method may decrease her milk supply? Okay, why you guys are not giving POP? That will be the even more favorable for the women who are on lactation or something. Very good. So the answer is D. The use of an IUD, barrier method, hormonal contraceptive agent contain only progesterone. All are appropriate method of birth control for breastfeeding women. It is best for nursing mother to avoid estrogen containing contraceptions because the estrogen preparation can inhibit lactation or decrease milk supply. A 23-year-old G1 at 39 weeks of gestation present to triage with a chief complaint of uterine contractions. They began 2 hours ago, are painful and occurring every 4 to 8 minutes. She report good fetal movement, no bleeding or leaking fluid. External tocometry show contraction every 5 to 15 minutes. Fetal monitoring show category 1 tracing. On examination, her cervix is 1 centimeter dilated, 80% effaced, and the fetal vertex is at -1 station. The patient had the same cervical examination in your office last week. What is the next most important step in the management? Anyone? Okay, those who are sending home to the patient, why you are doing so, and those who are even inducing the labor, why you are doing so. Performing in anatomy is totally wrong. Now, the debate on answer A and E. Those who are answering it, can you justify your statement? Very good, Dr. Lewis. You give the very correct answer. So the answer is A. This patient is most likely experiencing false labor or Braxton Hicks contraction. False labor is characterized by contraction that are irregular in timing and duration and do not result in any cervical dilation. The intensity of BH contraction does not change. The discomfort is mainly felt in the lower abdomen and the pain is usually relieved by sedation. In this case of true labor, the uterine contractions occur at regular intervals, tend to become increasingly more intense over time and result in progressive dilation and effacement of the cervix. Sedation does not stop the discomfort. There are three stages of labor. The first stage of labor is the interval between the onset of labor and full cervical dilation. The first stage consisting of a latent phase and an active phase. The second stage of labor begins with complete cervical dilation and ends with the delivery of the fetus. The third stage of labor is the time from delivery of the fetus to the expulsion of the placenta. Since this patient is not in true labor, this is the most number one reason. The best plan of management is to send her home and await spontaneous labor. In Australia, we will wait for the natural process, right? Doctor, all of the given scenario and the question is all giving the hint about the BH contractions, right? Another thing is that when you are sending this patient to the home is best because in Australia, three things you need to remember. One thing is this will be the C-section will be the last resort. When we compare that hysterectomy is the last resort, similar way they consider the C-section will be the last resort in their country. They will even induce on the point when there will be a distressing nature or something bad happening over there. They mostly prefer, even on the 41 weeks of gestation, that a patient is delivered naturally. So for ops and gynae, what you need to do is think first the natural thing and then you will go for the pathology. Now, these are the some gynae questions we have discussed previously. So these questions were very problematic in the November exam and October exam. Now we will start with some surgery questions. Then we will move to some psychiatric questions, right? 56-year-old previously healthy physician noticed that his eyes are yellow and he has been losing weight. On physical examination, the patient has jaundice and sclerectomy with a benign abdomen. Transcutaneous ultrasound of the abdomen demonstrated blurry ductal dilation without gallstones. Which of the following is most appropriate next step in the workup of this patient? I guess few people regarding this question is confused and most give the right answer. So, what you are expecting? What would be the diagnosis over here? Anyone?
Medium pulmonary mass that can be C head of the pancreas or distal cholangio.
Okay. So the answer is D. Painless jaundice with weight loss is a suspicious for a pancreatic cancer involving the head or uncinate process of the pancreas. A CT scan is the most appropriate study to evaluate for pancreatic mass. CT scan has a specificity of 95%, sensitivity 95% for tumor larger than 2 centimeter in diameter. Remember this marking. These will be important, right? PET scan may be a value in detecting small pancreatic tumor that are not seen on CT scan but sensitive and specific remaining to the establishment. An acute abdominal series is composed of 3 X-rays, upright chest X-ray, upright abdomen, and supine abdomen, and is useful in evaluating patient. Okay, patient for bowel perforation or bowel obstruction. ERCP is helpful in evaluating patient with obstructive jaundice without a detectable mass on CT scan. This is how we use Dr. Lewis ERCP. And EGD is not useful in the evaluation of a patient with a pancreatic mass. This is you need to remember about it, that which investigation is useful. Ultrasound, abdominal ultrasound will be the initial one. If they say that there will be none investigation is happen over there, and what will be the initial investigation of choice, or what we have to next, or they say the patient came to you having pain and something like that, what you will do? So initially, what we will do a person is go for the ultrasound. But in this question, they will asking about the next and best step. So that will be the CT. Okay, a 42-year-old man with a history of use of NSAIDs present with recurrent gastritis. The patient was diagnosed and treated for a Helicobacter pylori for 6 months ago. Which of the following tests provide the least invasive method to document eradication of the infection? Very good. Everyone gave the right answer. So the answer is B. We'll go for the UTI blood test as a non-invasive method of choice for documentation of eradication of H. pylori infection. This test sample the entire stomach and has sensitivity and specificity both greater than 95%. The test is performed by having the patient ingest a carbon isotope labeled urea. After ingestion, the urea will be metabolized to ammonia and labeled bicarbonate if a H. pylori infection is present. Labeled bicarbonate is excreted in the breath as labeled carbon dioxide, which can be quantified. Serology is another non-invasive test to establish the diagnosis of H. pylori infection. However, it cannot be used to assess eradication after therapy because antibody titers can remain high for over a year. Endoscopy with biopsy is necessary to provide a specimen for urea test, histologic evaluation, and culturing of gastric mucosa. So you need to see in the question that what they are asking. If they are asking the eradication thing, if they're asking the specimen, then we will change our investigation to endoscopy. And if there will be no urea blood test, then we go for the serology as well because it is also the non-invasive one. So you need to know that what in the question they are asking. 32-year-old alcoholic men recently immigrated from Mexico, present with right upper quadrant pain and fever for 2 weeks. CD of the abdomen demonstrated a non-rim enhancing fluid collection in the periphery of the right lobe of the liver. The patient's serology is positive for antibody to Antamoeba histolytica. So, which of the following is best initial management for the option? Doctor, there will be, regarding the question, you need to see that what will be the gold standard. If they're asking about the eradication and non-invasive, the gold standard will be urea blood test. If they're asking any lesion and you didn't even diagnose it, or initially they are asking it, then for initially the gold standard will be stool, we will give the stool for H. pylori. But if they are asking for the biopsy, then we will go for the endoscopy. You need to see what they are asking and which parameter they are asking. That's what I see, that your investigation, your everything will be changed according to the question. From next, best step, investigation of choice, everything will be changed on the depending upon the question. Yes, doctor, as we proceed with the questions, you will see that there will be lost a lot of question regarding it. So in this question, you will see they are asking which of the following is best initial management, right? They are not asking for the best choice of regarding it. So for the initial management, I guess most of people give the right answer that initially what we need to see is we need to treat the patient with drug. We will not even explore the patient directly on when we will ask the patient to come to the table because this patient is recently diagnosed. So what we want to do is initially we need to give a trial of anti-amoebic drugs, right? Amoebic liver abscess should be treated initially with metronidazole monotherapy as opposed to pyogenic liver abscess, which are treated initially with percutaneous catheter drainage and antibiotic against gram-negative and anaerobic organisms like example Klebsiella, E. coli, and so on. If improvement fails to occur, then other antimicrobial agent can be added. Abscess that are refractory to medical therapy, then we will go for the laparotomy. This is how we will go. If in the question, for suppose they say that anti-amoebic drugs are already giving, but there will be nothing happens. So what you will do? Then you will go for the percutaneous drainage. If they say that percutaneous drainage is already failed, like it is a spill in the peritoneum, and there will be peritonitis, what you will do? And what will be the best step in this situation? So there will be the laparotomy. This is how the question change, and this is how your investigations change. Getting my point? Okay, 62-year-old man has been noticing progressive difficulty swallowing first the solid food and now liquid as well. A barium study shows a ridge narrowing just below the cranial level. Endoscopic biopsy confirms a squamous cell CA. Which of the following provide the most accurate information regarding the T stage of an esophageal cancer? It's a tricky question. I guess most of you give the wrong answer regarding it. So the answer is D. Endoscopic ultrasound provide the most accurate T staging of an esophageal cancer. They just change the word and you all guys get confused. An experienced endoscopic ultrasonic grapher can identify the depth and length of the tumor, the degree of luminal compromise, the status of regional lymph node, and involvement of adjacent structure. In addition, biopsy samples can be obtained of the mass and the regional lymph node. The accuracy of EUS for T staging with the depth and vision for T1 lesion is 84% accurate and increases 95% accuracy for T4 lesion. CT is helpful, but its accuracy is only 57% for T staging. MRI can accurately detect T4 lesion and metastatic lesion, but overstage TNM status with only 74% accuracy. A PAT scan is reliable for detecting metastatic diseases, but is equal to CT scan for T staging. Bronchoscopy is useful in patients who present with a cough or cervical esophageal cancer to rule out a tracheoesophageal fistula or growth of tumor into the trachea. This is how they put the fancy words and everyone get confused. So most of you answer the A. So they were asking for the T staging for esophageal cancer. And in the CT, you can even diagnose the cancer, but you cannot even give the accuracy regarding the T staging. So the T staging, you need to go for the endoscopy. So this is how the slight change in the question will change the whole scenario and will find a difficulty and people get failed just because of a very little silly mistakes. This is a very minor mistake, but yes, just because of this, people get failed because surgery questions are all like this. I choose the questions only that will be find difficulty in the exam, and the people were very much concerned regarding gynae surgery and psychiatry. So I just put that questions a lot. 46-year-old woman who has recently diagnosed with Crohn's disease asked about the need for surgery. Which of the following finding would be an indication for an immediate exploratory laparotomy? Very good. This is the just because of perforation of bowel into the free abdominal cavity is obviously a surgical emergency. So this is the kind of easiest question and everybody, I guess, give the right answer. Okay, 48-year-old men present with jaundice, melena, and right upper quadrant abdominal pain after undergoing a percutaneous liver biopsy. Endoscopy shows blood coming from the ampulla of water. Which of the following is most appropriate first line of therapy for major hemophilia? Anyone? So the answer is B. Most of the people give the incorrect answer. So the first line therapy for major hemophilia is transarterial embolization. The classic triad of abdominal pain in the right upper quadrant, jaundice, and GI bleed is present in 30 to 40% of patients with hemophilia, with more frequent use of percutaneous liver procedures like hepatic cholangiogram, hepatic catheter. Iatrogenic injury has replaced other trauma as the most common cause of bloody bile. Other causes include spontaneous bleeding during anticoagulation, gallstone, parasitic infection, and abscess. And of course, the cancers. Angiography and endoscopy are useful diagnostic studies, and intrahepatic bleeding can be controlled by angiographic embolization in up to 95% of cases. Most cases of minor hemophilia can be managed conservatively with correction of coagulopathy, adequate biliary drainage, and close monitoring. Surgical treatment is reserved for cases in which conservative therapy and TE have been failed. Percutaneous hepatic biliary drainage is a cause of hemophilia with the incidence of up to 10%. So you see in the question, they ask you that which of the following most appropriate first line. So they in the explanation, it is already told that first line will be the TEA, right? That will be the embolization. And if the embolization is failed, then we will go for the surgical treatment. And even they say that a percutaneous transhepatic biliary drainage can also causes the hemophilia as well. So if they say that embolization is done and still the patient is in hemophilia, then what will be the investigation of choice over there? So that will be the surgical treatment over there. But if they say what will be the initial choice over there when there is nothing is done on this case, so that will be the embolization. Based on the management, based on the how patient is appearing, based on the what asking in the question, you need to answer it. Okay, 42-year-old homeless man present with a 3-week history of shortness of breath, fever, and pleuritic chest pain. Chest X-ray reveal a large left pleural effusion. Thoracocentesis reveal thick fluorine appearing fluid, which is found to have glucose less than 40 mg per dl and a pH of 6.5. A chest tube is placed, but the pleural effusion persists. Which of the following is most appropriate management of this patient? Anyone? This is the easiest one. Okay, I guess most of the people is very confused with the surgery. I guess most of you give the incorrect answer regarding it. So the answer is E, that is the patient has an empyema or the accumulation of the pus in the pleural cavity based on the history, 3 weeks of symptoms and fluid analysis demonstrating a glucose level less than 40 and pH less than 7. So it's thick inconsistency. The patient's emphysema is the empyema is in most advanced stage or the chronic organized phase. In this phase, the fluid collection is loculated and depositions of fibrin create a thick pleural ring, which prevent apposition of the lung to the parietal pleura. Re-expansion of the lung requires thoracotomy with decortication to remove the thick pleural fluid and the pleural ring. Antibiotic therapy tailored to the organism identified is necessary but not sufficient to treat an empyema just because it is very thick secretion. So along with the re-expansion, like along with thoracotomy, what you need to do is you need to do decortication as well along with antibiotic, because the if you are doing any type of decortication or you if you are even doing the thoracotomy, what you need to do is you need to give the antibiotic therapy as well. So this is the how you can approach the patient. Okay, to 63-year-old woman with chronic COPD present with a severe. It differs on the question. They will mention it. They will mention it that where what you will do in the constant. You see, they didn't even put in the option regarding installation or decortication. If they put it, like we can say the terminologies, if they put it, you need to mention or you will select over this. Okay, 63-year-old woman with COPD present with a several weeks history of fever, night sweat, weight loss, and cough. Her chest X-rays noted to have a density in left upper lobe with a relatively thin wall cavity. Bronchoscopy and CT are suggested for a lung abscess rather than malignant process. Which of the following is most appropriate initial management of this patient? Now they are asking what you initially do. Already investigation is done. Now I guess everybody get to know how to approach to the surgery question, right? Now you guys are giving the right answer. So what you need to do is you need an initial treatment of a lung abscesses. You need to give antibiotics. Once the diagnosis has been made, systemic antibiotic directed against the causative agent. The duration of therapy is depend on the severity of the underlying pneumonia that resulted in the abscess and can last up to 12 weeks. Often the abscess drains spontaneously via the tracheobronchial tree, but if it is failed to resolve with medical therapy, intervention may be required, ranging from percutaneous to surgical drainage of the abscess or resectional therapy. If in the similar way they say that antibiotic is of no use, then what you will do from these options? Anyone? Why you guys are not going for the percutaneous drainage first? Sorry, why you guys are not going for the tube thoracostomy? That's why I'm saying that you need what you need to do is you need to see the initial management and what they are asking in the question. Either they are asking for the complication initially, after initial is failed. These are the terminologies and things you need to know what they are asking, right? Okay, 64-year-old woman complains of right calf pain and swelling. She recently underwent an uncomplicated left hemicolectomy for diverticular disease. A duplex ultrasound confirmed the presence of DVT of the calf. Which of the following most appropriately initially management of this patient? No, doctor, I just asked that why you are not going with this option. Very good. So this will be the C. The initial treatment for DVT is therapeutic heparinization with either IV heparin or low molecular weight heparin. Administer subcutaneously even following prompt aggressive treatment of DVT of the calf. As many as half of the affected patient will develop symptoms of chronic venous hypertension, and a large number will have abnormal venous hemodynamic finding. For long-term anticoagulant for patient with DVT is achieved with warfarin. This is very hallmark. You can even mark this line as well. The appropriate duration of therapy is based on the risk factors, the number of previous attacks, location, Because we will go for the warfarin. As I told you that long-term anticoagulant for patient with DVT is achieved with warfarin. This is I mentioned in the question right now. Pneumatic compression stockings are an acceptable prophylactic measure in patient with a moderate risk of DVT. However, they are not effective against established thrombosis. This is also a very important line what you need to mark it. A small percentage of patient undergoing a small percent of a patient undergoing appropriate treatment of DVT can still develop a pulmonary embolism. These patients would then be candidates for an IV inferior vena cava filter. Thrombotic therapy is not recommended treatment for a routine DVT. It is reserved for patients with phylexmia for relief of significant venous obstruction. Doctor, it is depend on that either they are giving in the question either 3 months, 6 months, or how long the duration they will mention. So on the question, it will be depend. And on the scenario and on the given question, either it is having any type of co-mops, either it is a first attack or second attack. For this, I will have in the lecture, I will have a chart. So this chart you will see and then you can answer from this chart. With the co-mops, without co-mops, first attack, second attack. So according to that thing and according from the question, you will get to know that either it is used for 3 months, 6 months or 12 months. Okay, 58-year-old men present with a pain in the left leg after waking more than one block, that is relief with rest. On physical examination, distal pulses are not palpable in the left foot and there is dry gangrene on the tip of his left fifth toe. An ankle ABI index on the same side is 0.5. Which of the patient's symptom or sign of the arterial insufficiency qualifies him for reconstructive arterial surgery of the left lower extremity? Anyone? Okay, most of the answering that absent palpable pulses, don't you see that already patient develop a gangrene? So the major threat to this patient with arterial occlusive diseases, limb loss, breast pain, and gangrene represent advanced stage of arterial insufficiency and warrant arterial reconstructive surgery whenever clinically feasible. See, before, because pulse loss will be not that much stat as compared to the gangrene, because that is the already very advanced stage, right? This patient does not have rest pain, which is defined as persistent pain in the extremity. Claudication is most cases reflect as persistent pain. Mild ischemia, the majority of affected patients are successfully managed without surgery. Most will stabilize or improve with development of increased collateral blood flow following instruction of a program of daily exercise, cessation of smoking, and weight loss. And ABI is useful preoperative tool but does not by itself determine whether someone is candidate for revascularization. Palpable pulses are usually absent in patients with claudication. Vasodilator drugs have been shown to have little benefit in the conservative management of intermittent claudication. So this in this case, because in the previous case, dry gangrene is already developed. So for this, the reason is only the toe gangrene. If the reason is toe gangrene is not developed, then you can go for the absent palpable pulses. That's why I'm saying that just see the question in STEM. Things will be changed accordingly. Okay, 60-year-old man sees a urologist for what he described as bloody urine, as urine sample is positive for cytologic evidence of malignancy. Cytoscopy confirmed the presence of superficial transition cell carcinoma. Which of the following is the recommended treatment for stage A, transition cell carcinoma of bladder? what I realize, what I feel like, that surgery is kind of difficult for you. Like everybody is get confusing in surgical question. Very good, doctor. So in this question, the answer is D. 90% of bladder cancers are of transition cell origin, most prevalent among men with a history of heavy smoking, and is usually multifactorial, superficial. Even when recurrent, when the disease is still superficial, transurethral resection of visible lesion and intravascular chemotherapy are most often recommended. More radical surgical resection, systemic chemotherapy, and radiation are reserved for advanced stage of the disease. Just three more surgical questions, then probably the psychiatric questions. I guess surgical questions you guys find difficult. Don't worry. If people who are with regular course and recall course, we will go through the surgical questions more. You will go through it, right? Don't get confused. Just answer it whatever you know about it. Okay, 32-year-old man present with asymptomatic mass in his right testicle. On examination, the mass cannot be transilluminated. Ultrasound shows solid mass in right testicle. Which of the following most accurate method in obtaining a diagnosis of testicular cancer? Okay, so the answer is E. We will go for the most accurate method. That will be the histologic information. In case of testicular cancer, a radical inguinal orchiectomy with high ligation of spermatic cord near the internal linguinal ring is the procedure of choice to provide histological evaluation of the tumor. Violation of this scrotum must be avoided because it may alter the lymphatic drainage of the testis and lead to a poor outcome. Serum levels of alpha fetoprotein and beta HCG are elevated up to 85% with non-seminimatous germ cell tumor. However, these tests are not sensitive or specific enough to establish diagnosis of particular cancer in the absence of histologic confirmation. So over here is we will go for the radical inguinal orchiectomy. Yes, doctor, why not? Because in these type of cancers, what the most even have a fear of, whatever you are go for in incisional excisional, there will be a very fear of spreading of a cancer, right? The spreading of cancer while diagnosing it, you will even spread the cancer cells, so that's why we will not go for excisional or incisional biopsy in these cases. That's why we will go for the radical inguinal orchiectomy. Yes. Okay, 45-year-old woman present with a 7 centimeter renal cell carcinoma with radiological evidence of abdominal lymph node involvement with no distant metastasis. Which of the following is most appropriate management of this patient? Okay, so the then only blunder you guys do over here is renal cell carcinoma is not responsive to radiation and chemotherapy. So therefore, radical nephrectomy remains the main treatment for localized cancer. A radical nephrectomy should be offered as a possible curative procedure in this patient because many nodes initially suspected of having metastasis disease on imaging are enlarged due to reactive inflammation. So you cannot even go for the radiation and chemotherapy because these are not responsive. The only option left is radical nephrectomy. These are the very small blunders you do while solving the questions. No worries, that will be the just start. You will even define it, right? You will go good with that things. Okay, 65-year-old man present with acute onset of pain, swelling and erythema of the left knee. He denies previous episodes of trauma with the knee. The differential diagnosis includes septic arthritis and gout. Which of the following is the best study to differentiate between gout and septic arthritis? I guess this is the easiest one, and anybody can go through it because this is not as much as difficult as compared to the previous one, right? Very good. So the patient presentation is consistent with both septic arthritis and gout. The most definitive study to differentiate between two diagnoses is synovial fluid aspiration. This is important because in gout, urate crystals are seen. In septic arthritis, synovial fluid aspirate demonstrate bacterial white cells with high neutrophil. And white cells can be elevated on both processes. You need to know about it because you guys get confused when they give the gouty scenario. X-ray and MRI show tissue swelling around the joint consistent with both conditions. A bone scan would target the area of inflammation but not give any information as the source of the inflammation. Last question regarding surgery, then the question from the psychiatry. In a failed suicidal gesture, sorry, the first question I guess from the surgery, or I guess it's from ortho. In a failed suicide gesture, a depressed student serves a radial nerve at the wrist. So, which of the following is an expected disability? Very good. Only Dr. Mubin get the right answer. Give the right answer. So, in this question, what is happened that these right answer and injury to the radial nerve at the wrist would cause primarily sensory abnormality, right? There are some of the hand from the radial aspect of the foredigit over the thumb, including the thenar pad and thumb web, becomes insensate after the severance of the radial nerve at the wrist. Radial injury more proximally would impair extension of the wrist and digits as well as foramen supination. So what you need to remember that where the radial injury is happening, either it is more proximally, either it is more radially, with which type or which location it is even more tightly to cut or harm is already happened, right? So yeah, we move to the psychiatry. 25-year-old woman is dropped on the door step of a local emergency room by two men who immediately leave by car. She is agitated and anxious, and she keeps bruising her arm and legs to get rid of the bugs. She clutches at her chest, moaning in pain. Her pupils are wide and her blood pressure is elevated. So, which of the following substance is most likely used? No, doctor, LSD cannot causes these symptoms. LSD can causes visual hallucinations. That would be the very bad. Even the person sees her face on mirror, see, they say that my face is melting. Yes, everybody is right, I guess. Cocaine intoxication is characterized by euphoria, but suspiciousness, agitation, anxiety, and hyperactivity are also typical presentation. The sympathetic stimulation such as tachycardia, cardiac arrhythmias, and hypertension, pupillary dilation, perception, and chills are also present. Visual and tactile hallucination, including hallucination of bugs crawling on the skin, that will be the cause. Formication may present in cocaine-induced delirium. Among of the most serious acute medical complication associated with the issue of high dose of cocaine are coronary spasm, MI, intracranial hemorrhages, ischemia, cerebral infarction, and seizures as well. Okay, 32-year-old Asian woman becomes flushed and nauseated immediately after drinking half a glass of wine. She is noted to have slurred speech, ataxia, and nystagmus as well. She is brought to the emergency department by her concerned friends. Which of the following is most likely diagnosis? Okay, I guess everyone give the right answer. So this is the alcohol intoxication. Among Asian women and men, 10% lack from the form of acetaldehyde is responsible for metabolizing low blood concentration of acetaldehyde. Approximately 40% of Asian men and women are heterozygous for this specific enzyme variation because of the rapid accumulation of the acetaldehyde. Homozygous individual develop facial flushing, nausea, vomiting after ingestion of small quantity of alcohol, which are the common side effect of alcohol intoxication and occur much earlier than the normal. Heterozygous individual can tolerate some alcohol but are more sensitive to its effect. This enzyme variation is found only in people of Asian descent. Okay, 16-year-old boy with a police record of arrest for breaking and entering assault and battery and drug possession is found dead in a room with a plastic bag on his head. For several months, he had been experiencing headache, trauma, muscular weakness, unsteady gait, and tingling sensation in his hand and feet. These symptoms suggest that he was addicted to which of the following substance? So the answer is D, that is inhalant abuse is associated with very serious medical problem, hearing loss, peripheral neuritis, paresthesia, cerebral signs, and motor impairment. Commonly neurological manifestation, muscle weakness like rhabdomyolysis, irreversible hepatic and renal damage, cardiovascular symptoms, and gastrointestinal symptoms as well. You know what? The petrol inhalant and something, it is very common in Aboriginal population. So you need to know that which substance causes which type of symptoms. This is important. That's why I put in the BCQs, right? Okay, 40-year-old man comes to the emergency room with the symptoms of tachycardia, diaphoresis, mydriasis, and hyperthermia. He also shows muscle twitching and clonus. His medication include a protease inhibitor for AIDS and fluoxetine 20 milligram daily, which was started a week ago. What is the problem that most likely brought this man to the emergency room? Anyone? I guess everyone give the right answer. That will be the serotonin syndrome. Antiviral agents have many side effects. They are multiplied by hepatic oxidase system and can therefore increase the circulating levels of many psychotropic drugs, including bupropion, mepridine, benzodiazepine, and SSRIs as well. So, 25-year-old woman with bipolar disorder develop a high fever with chills, bleeding gum, extreme fatigue, and pallor 3 weeks after starting or carbamazepine. Which of the following is she most likely experiencing? Yes, very good. The answer is B. Aplastic anemia, rare, idiosyncratic, non-dose related side effect of carbamazepine. Stevens-Johnson syndrome is potentially life-threatening. Exfoliating dermatitis also rarely associated with carbamazepine treatment that usually develops shortly after starting the drug. Neuroleptics and serotonin malignant hyperthermia are not associated with this medication. Remember this thing. That will be more pronounced for SSRIs and antipsychotics. Okay, 53-year-old man is admitted to psychiatry after a serious suicide attempt. He remained nearly catatonic on the unit, refusing to either eat or drink. He also remained quite suicidal and remained one-to-one observation all the time. So which of the following most appropriate for the treatment? Anyone? I am very happy that my regular students are giving the regular course student giving the right answer, and I'm very happy with that. That psychiatry is, I guess, more or less very clear to you guys. So the answer is ECD because the patient is in catatonia, suicidal attempt. So, clearly suffering from major depressive disorder, already one suicidal attempt, refusing to eat and refusing to drink. So, the in case the only thing that can work the patient is ECT. Okay, a 9-year-old girl is brought to the physician because she is noted to be easily distractible and fidgety and it's generally difficult to get focus at school. The physician started the girl on retinalin. Which of the following cautions about the drug should be physician give the child's mother? Okay, so it's B. Retinol is well known to cause insomnia and thus should not be given afternoon. Other side effects may include reduced appetite, headache, and GI disturbance, and the emergence of the tick. So there's no interaction with the food, so it can given with the food, but it causes insomnia. That's why we are not giving after the afternoon. So that will kid will be the very much active, and if it is not sleeping in the night, that will be causing the patient to go in the mania. Okay, a 19-year-old girl is taken hostage with other bystanders during an armed robbery. She is freed by police intervention after 10 hours of captivity, but only after she has witnessed the shooting death of the two of her captors. Month after this event, she has flashback and frightening nightmares. She startles at every noise and she experiencing acute anxiety whenever she is reminded of the robbery. So, which of the following medication would most likely help decrease this patient's hyperarousal? So this is the A, that will be the clonidine. Practically every class of medication has been used to treat PTSD, including every family of antidepressant, mood stabilizer, anxiolytic, and inhibitors of adrenergic activity such as clonidine and propanol as well. Because benzodiazepines are not mentioned over there, right? Clonidine and beta blocker can be particularly useful alone or in combination with other medication to treat symptoms of hyperarousal. These drugs block the adrenergic symptoms of hyperarousal, which in turn may allow patient with PTSD to better control feelings of anger, rage, or panic. Or even the sometimes the patients say that a tremor are going on, so they can even control the tremor as well. Either the beta blocker, propanol is mentioned over there, or either the clonidine is mentioned over there. So we can augment this to just lower down the symptoms along with the medications of antidepressant or anxiolytic, right? Okay, 56-year-old woman in the last stage of amyotrophic lateral sclerosis asked for her life support to be stopped and to be allowed to die. Her family member disagree with her decision and go to the court to keep the patient alive. A psychiatric evaluation finds the patient mentally sound and fully able to understand the consequences of her decision, and a judgment declares her competent. Which of the following action would be next taken? Remember this thing that euthanasia is now even in Tasmania in many states that it is legal, right? And another thing is that this patient is psychiatrically competent. Always remember two things in mind and then answer this question. So I guess most of the people are right. A 981 court case rule, the patient have an absolute right to refuse treatment if they are not competent. A guardian may then authorize the treatment. In this case, patient is competent, so the life support should be withdrawn as she requests. Last question. A 13-year-old boy is brought to the ER by his parents after he set fire to the room. He has been seen in the ER on multiple occasions for a variety of symptoms, including suicidality, homicidality, uncontrollable tantrums, and pica. Of the symptoms, which of the following is most likely seen in Alderson when seen by a psychiatrist in the emergency room? Anyone? This is B. That will be the suicidal behavior, right? There is the most common reason for psychiatrists to see an Alderson in emergency setting. Important is the evaluation of these children and assessment of the stability and supportiveness of the home environment and caregiver competence in taking care of the Alderson. These factors will figure in to be clinician's decision as to whether a potentially suicidal Alderson must be administered to an inpatient unit or may be released home to be closely monitored. So along with this, we just completed our question answer sessions. Hope you find it useful. I just put all the explanation clearly. We'll see you in recall session and with regular session groups. Hope you understand the questions and the scenarios and everything. With this, we are just ending our session today. Thank you, everyone.
Thank you, Dr. Nabira.
Welcome, dear doctor.